Okay, now let's move on to the progressive stage of shock. Ideally, as we talked about before, we would like to recognize and initiate interventions early so that we don't get to the progressive state of shock. But shock state, if it continues, the patient's condition will worsen and will become increasingly worse as we go along. One of the things that we'll see with the progressive state of shock is the MAP will decrease more than 20 from the baseline, with an average of a systolic blood pressure of less than 90 most of the time. Hemodynamic mechanisms continue, or compensatory mechanisms continue, but the cells don't get adequate supplies of oxygen and nutrients at this point. When we're looking at the mean arterial pressure, we look at a minimum of 60 is required to nourish the coronary arteries, the brain, and if the mean arterial pressure drops below this for any length of time, vital organs are deprived of oxygen. Let's look at some of the other concepts that are affected during the progressive stage of shock. During the progressive stage of shock, oxygenation is affected. Respirations are rapid and shallow, as we talked about before. They are trying to increase the respiratory process in the lungs with the increased respirations and increased oxygen available to diffuse into the hemoglobin so that we have more oxygen per hemoglobin molecule that can be carried through perfusion. At this point, the patient may start developing crackles in their lungs. Now, crackles in their lungs at this point with most types of shock is not related to a cardiogenic issue. It's related to a respiratory issue. And what we want to think about is ARDS, with that non-cardiogenic pulmonary edema that patients will see. We'll see because we have decreased pulmonary blood flow, and that decreased pulmonary blood flow will decrease the arterial oxygen levels, and carbon dioxide levels will increase. So that's what we're looking at this point with oxygenation, is the beginning of respiratory failure. At the beginning of respiratory failure with hypoxia, it can progress to a hypoxic and hypercapnic failure. The poorly perfused alveoli will stop producing surfactant, and then we'll start seeing alveolar collapse. With the decrease of surfactant, we see decreased compliance in the lungs, and that can lead to ARDS. ARDS being a process that we see that has a precipitating event. Shock is a very common precipitating event that we see prior to patients developing ARDS. Okay, let's look at perfusion right now, or just, specific to perfusion. We've talked about perfusion a lot and what kind of things cause decreased perfusion, but let's talk about it in relation to the heart. So now that we have a decreased perfusion state throughout our body with the shock, we don't have an adequate blood supply to the heart. So the blood supply of the coronary arteries is compromised. Compromised in that is going to lead to myocardial ischemia, and it will lead to dysrhythmias. Some of the common dysrhythmias that we see with patients who have oxygenation issues are PVCs, or ventricular dysrhythmias. And ventricular dysrhythmias, as the heart continues to get more and more ischemic, can be deadly with VTAC or VFib. So that's what we're looking at with this situation. Usually is ventricular dysrhythmias with the patients, and the development of PVCs is an ominous sign and does need to be treated. We also see tachycardias with the patients, and these tachycardias lots of times are sinus tachycardias. They can develop an atrial tachycardia, but that atrial tachycardia is related to that stimulation of the sympathetic nervous system, and we'll have to decrease that stimulation of the sympathetic nervous system. Can we treat and slow down this heart rate? Well, that's kind of a catch-22 kind of issue. If you decrease the heart rate, you're going to decrease the perfusion. So at this point in time, what we really want to do is try to improve our perfusion to the heart, and then that will in turn decrease the heart rate. Complaints of chest pain is not uncommon in the progressive stage. When they complain of chest pain, one of the things that you need to really remember is that that's because their myocardium is ischemic. It can lead to an MI. It can lead to a low perfusion MI because they have ischemic areas in their heart. Their cardiac enzymes will elevate, and that elevation of cardiac enzymes is evident of that myocardial infarction. Perfusion and oxygenation combined are necessary to try to improve or maintain blood flow to the brain. As the brain's blood flow or perfusion or oxygenation decreases, their mental status deteriorates. Decreased cerebral perfusion and cerebral hypoxia causes changes in level of consciousness. Those changes in level of consciousness will be subtle in the beginning, but they will progressively get worse. As lethargy increases, the patient begins to lose consciousness, and we can even get to the point with these patients that their pupils will dilate and they can be sluggish to react to light because of decreased perfusion and decreased oxygen to the brain. Fluid electrolytes in the progressive stage of shock, we see as the MAP continues to go down, glomerular filtration rate is affected and can decrease. Most likely at this stage it does decrease, causing a pre-renal acute kidney injury. This pre-renal acute kidney injury also affects fluid shifts, acid-base balance, and urinary output definitely at this point is going to be decreased. We can expect that the kidneys are not going to recover until we see improvement in the perfusion. And when you go back and look at acute kidney injury, once the insult or injury has occurred to the kidney, it may take them weeks to months to a year to recover from this injury. Metabolism. This is something we've not talked about a lot with the stage of shock yet, because we really don't start seeing this organ dysfunction and as much until we get to the progressive stages of shock. And in the progressive stages of shock, we do see liver dysfunction. The decreased blood flow to the liver impairs the liver's abilities to carry on its metabolic processes, eliminating toxins from the body, the phagocytic functions of the liver, and the patient is not able to metabolize medications, metabolic waste such as ammonia and lactic acid as efficiently as it is. And so we do see that buildup of lactic acid and we see that buildup of ammonia as well because of that. The patient is more susceptible to infection because the liver is not filtering bacteria anymore. So without that filtration, then we have bacteria that's in our body for a longer period of time. Liver enzymes and bilirubin levels are elevated during the progressive stage of shock related to the dysfunction of the liver. We will see other metabolic issues, as I mentioned earlier. We will see ischemia of the GI tract because of blood being shunted away from the GI tract. One thing that we did not discuss is the patient's increased risk for stress ulcers during this period of time. And these stress ulcers can develop fairly quickly. So prophylaxis against stress ulcers with a Protonix or some type of proton pump inhibitor is frequently used. The small intestines, the mucosa in the small intestines can become necrotic and slough off. Our small intestine and large intestine get a lot of their nutrients from the food source themselves inside the intestine. And whenever they don't have that food source, then the mucosa will break down. The mucosa breaking down in the intestine is a very serious situation because inside of our intestinal system, as we well know, we have gram-negative bacteria, E. coli, and other dangerous bacteria in our GI system. And as long as that mucosa is intact, that bacteria is beneficial to our digestive system. But when that mucosa breaks down, then there can occur a translocation of bacteria from our intestines into the bloodstream. So a patient that may be in shock from hypovolemia now may develop a a systemic infection, and along with having hypovolemic shock, they may have sepsis, and then that sepsis contributes to issues with shock and metabolic dysfunction. So that's some of the things that we need to think about when we look at what's going on with our GI system, because our GI system is very important, although it is one of the first systems to be compromised whenever we have a patient that's in shock. Okay, let's talk a little bit about stress hyperglycemia, or their glucose levels rising whenever they're in stress. We haven't talked about this much, but glucose levels rising in relation to stress does affect patient outcomes. There are some conflicting studies out there right now. Some of the studies show that stress hyperglycemia may be a protected mechanism to have glucose available to our cells that are not non-insulin dependent cells for the uptake of that glucose. Others show that increase in cortisol levels, which cortisol is what stimulates the stress hyperglycemia, can also increase the pro-inflammatory cytokines and things that we talked about earlier when we talked about sepsis. And that can cause that hyperglycemia, or that stress hyperglycemia. Tight management of glucose has not really been that effective in studies yet to show that it improves outcomes, but just anecdotal information shows that, you know, we want their cells to be able to uptake the glucose so that they'll have the glucose available for their cellular metabolism. So stress hyperglycemia is something that we do need to be concerned about. We do need to be aware of it, and we need to know that keep a close eye on the patient's glucose levels when they're in shock. Cellular regulation in shock. We talked briefly when we talked about sepsis about DIC, disseminated intravascular coagulation, and that can be a complication of any type of shock. The change in the coags, the increase in D-dimer. D-dimers have taken the place of FTP, fibrin split products in lots of labs now, so that's one of the things that we'll be looking for, or decreased levels of fibrinogen. Widespread clotting and bleeding occurring simultaneously throughout the body, so we see bruises or ecchymosis. We see bleeding or petechiae may appear in the skin, or I don't have it listed here, but you can also see purpura. But purpura is kind of like clumps of petechiae. So you see petechiae to petechiae usually, and then as it worsens, you'll see petechiae and purpura. So we want to monitor our coag times, PT and PTT. They will be prolonged and will progressively get more prolonged as the patient develops these coagulopathies. Fibrinogen levels and D-dimers are also very important for us to monitor to see if our patient is improving or if their DIC is worsening. Okay, medical management and nursing management when we have a patient in shock. What type of things do we need to do? Well, it depends on the type of shock, because we want to identify the underlying cause of the shock. But overall, with most shocks, we are going to administer IV fluids, usually isotonic IV fluids, either normal saline or lactated ringers, and medications to restore tissue perfusion. The goals that we're looking at with shock is that we want to optimize our intravascular volume, and we want to support the pumping action of the heart. So some medications that we give may be to improve contractility, improvement in the competence of the vascular system. So we want to stop the leaking from the vascular system, the shift of fluids and movement from the vascular system. We want to try to stabilize the cell membranes so that we can keep fluids where they need to be and where they're supposed to be. Early intervention with nutritional support. Usually we want to do that because we want to feed the gut. We want to keep the mucosal lining of the gut healthy. We may use antacids or histamine blockers. We may also use proton pump inhibitors or other agents to help reduce the risk of GI ulceration and bleeding. So let's take a quick review of the pathophysiology of shock in this progressive stage. The patient already has decreased cardiac output when they start in the progressive stage, so that leads to tissue hypoperfusion. Cells switch from aerobic to anaerobic metabolism, causing the buildup of lactic acid and lactic acid production. Cell function ceases, cells swell, membranes become more permeable, so cells start leaking fluids. The electrolytes and fluids seep in and out of the cell. The potassium and sodium pumps are impaired, so regulation of electrolytes is impaired. Then the cells are damaged, and once the cells are damaged, then that leads to cell death. So that's what we're looking at in the progressive stage. That's why we would really like to stop shock in the non-progressive stage, or as early as we can, with early interventions. And those early interventions we're going to talk about when we talk about the different types of shock. Okay, now that we've talked about the other stages of shock, let's talk about the irreversible or the refractory phase of shock. The refractory stage of shock is the various compensatory mechanisms or treatments that we've used have not reversed the shock at this stage. The patient, death is actually imminent at the stage, refractory stage of shock. Tissues are damaged to such a degree that repair is not possible. Blood pressure remains very low. We have renal failure, we have liver failure, we have our overwhelming metabolic acidosis. Multi-organ dysfunction has occurred and death is imminent at this stage of shock. So much damage has occurred at this stage of shock, it is not reversible. Signs of this stage of shock, we will see a rapid loss of consciousness. Usually we will see the heart affected dramatically at this stage. With myocardial dysfunction, the heart muscle will dysfunction. You may see a heart rate with no pulse. The heart rate that you see typically is very slow. The patient could have a bradycardia, but the cardiac output is so low that peripheral pulses will not be palpable. The changes are profound, and at this point, even though we continue therapy, there's really not anything that we can do to reverse the damage to the cells and the damage to the organs. So the patient is going to die once they reach this stage of shock. So during this stage of shock, what we need to do, and like I said before, with our patients' families, we need to keep the patient informed as much as we can up to this point. At this point, the patient is going to be unconscious. We need to keep the families informed, let the families know what's going on, make sure they understand what's going on, allow more visiting time for the patient's family. They know that death is imminent. Try to meet some family needs at this point in time. This is not typically a time that we discontinue therapies. We let the therapies continue, but the therapies are going to be ineffective. So we're not going to see a reversal of what's going on with the organ damage that this patient has already succumbed to. So focus on the family, focused on their grieving process and what we can do as healthcare providers to facilitate that for them. Okay, at this point, we've talked about all the stages of shock and what happens with a patient in shock. But I think that this is a really interesting picture of what happens in shock that we don't see. This is a picture. A on the left-hand side shows us what our normal circulation is, and I think that this picture is actually taken under a patient's tongue. So it's a central part of circulation that we see here. And on the right-hand side is the patient that is in shock. So this is the very same area, this is the very same picture, and you can see the limited blood supply and decreased perfusion on the right-hand side of the picture. So I think this gives us a pretty good idea of what's really going on with perfusion in shock. So let's look at what we need to do for our nursing management of our patients in relation to shock. Nursing management, we need to identify our patients that are at risk, recognize shock quickly in the early stages, treat the primary cause of the shock, initiate the therapy to modify, any kind of systemic response the patient may have, protect target organs. We want to protect our heart, lungs, liver, pancreas, brain, and give supportive care. Now, supportive care, what does that mean? Well, what that means is that we don't want our patients to get any sicker than they already are. So if we have a patient in shock and they're on the ventilator because they're experiencing some respiratory difficulty or respiratory failure, we want to make sure that we don't break protocols so that they get a ventilator-associated pneumonia. A patient that is in shock will typically have an indwelling Foley catheter, and we know the risk for urosepsis with an indwelling Foley catheter, and we need to prevent our patient from getting these infections. Even if they are septic already from one source, we don't want them to get an infection from another source. That's going to compound the problem and decrease their chance of survival. Another issue that's a big issue is our patients that are in shock have mobility issues. So we need to make sure that we turn them, that we keep them clean, we keep their skin dry, we keep their skin well moisturized. We don't want to see any skin breakdown. We don't want to see muscle atrophy during this period of time. So if the patient can tolerate it, and sometimes they can't because of low perfusion states, but at the point when you get your patient to where they can tolerate any type of range of motion, it just may be a small amount of range of motion, hands and feet, or what you can do will help them as they recover, to help them recover their mobility. We also need to do that nutritional support that we were talking about to try to prevent any secondary or any other infections from other sites like the GI tract. So those are the things we need to look at the patient from a holistic view. We need to make good judgments. Anytime that we perform an intervention, we need to make sure that we evaluate the effectiveness of that intervention toward our goal. Did it increase perfusion? Did it not increase perfusion? If it didn't increase perfusion, go back and reassess our patients each time and then discuss with the physician or the healthcare team what else do we need to do. And make sure that as we're given this supportive care, we include their family in the supportive care. Make sure that our communication lines are good, establish trust and relationship with the family. This patient is in a very high-risk situation, and the better your communication is with the family, then the better the outcome is going to be for that relationship and that communication, irregardless of the outcome of the patient. Always remember as well that prevention is better than any cure that we can come up with. So if we can prevent complications for our patients that are in shock and then just have to worry about focusing on the shock with this particular patient, then that's going to be better for them in the long run. More nursing management and nursing responsibilities that we want to look at in preventing complications. I think I mentioned some of these. I can't say often enough, strict aseptic techniques, follow protocols whenever you're administering medications through an intravenous line, whenever you're doing site care to an intravenous line. Monitor for early signs of complications. Monitor trends of signs of complications. Position for comfort, prevent pulmonary complications in the turning and, trying to maintain hydration, trying to maintain mouth care definitely on patients to prevent ventilator-associated pneumonias, maintain their skin integrity, support for family members, and make sure that you have time to answer questions for family members and make sure they have time to, you allow them to participate in the plan of care if that's possible. Just a few other things when we're looking at the patient. These patients that are in shock, if they get to definitely the non-progressive stage, if we don't stop it very early, then they're going to be in an ICU environment. In an ICU environment, there is close monitoring. Monitoring of urine output, medication administration is going to be complex. And the mechanical ventilation, they may be on dialysis, And we may be using other devices to support organs like an intra-aortic balloon pump to support cardiac. Those are the kinds of things that you're going to see with these patients. If we're not able to stop this shock very early onset, and reverse whatever the cause is, and the patient progresses, they're going to be in ICU. When looking at our patients with shock, we want to make sure that we understand the ultimate goal with any patient in shock is to restore this tissue perfusion, or at least have adequate tissue perfusion, normalize their blood pressure, or at least have an adequate blood pressure, support their vital organs to minimize damage to the organs, and optimize that organ function. We don't want these patients to leave the hospital with long-term deficits, so we would like to prevent any other problems that we have with immobility, skin breakdown, problems with the GI tract, stress ulceration, those kind of things. So the goals that we're looking for these patients all relate to tissue perfusion and maximizing that tissue perfusion. And just remember, whenever you're studying and think about the patients in shock and how critical that they are, that our patients are trusting us. They're putting their life in our hands. And in this situation, it is a life or death situation. We are capable as nurses to be able to intervene early and prevent any complications or the progression of the shock.